That study is fully enrolled and is maturing as we speak. We have a companion study similar to that design on top of children who've received mRNA that's enrolling right now.
And another question. So with respect to the Pfizer product, Dr. Jared, and actually I guess for Moderna as well, we really don't have data on any less than 12-year-olds currently. And so we are in the process of trying to recommend this vaccine where the data is just ongoing studies at this point, right?
I'm happy to start with that one. This is Fran Pretty from Moderna. We very rapidly conducted the study that I presented today in order to have clinical data for an XBB-containing vaccine, to provide the most current information on immune responses, but also safety for strain selection this year. But recognizing that the study could not include all age groups, we do note that this vaccine, of course, uses the same platform as the previous Moderna COVID-19 vaccines, and that safety profile has really been extremely well characterized with over 1 billion doses given worldwide, and over 50,000 adults and children evaluated safety in clinical trial setting. That includes over 16,000 children from ages 6 months to 18 years have received the platform vaccine, the Moderna mRNA COVID-19 vaccine in clinical trial settings. So, and the data I showed today, although not in children, does show a very consistent reactogenicity profile of updated vaccine compared to the prior one. So we feel that the safety profile will carry over with the updated vaccines across all age groups. Thank you.
Hi, this is Kayvon Majard from Pfizer. We have evaluated our vaccine in pediatric age groups all throughout the course of the availability of the vaccine in the original formulation as well as the bivalent BA.4/5 formulation. And all the data, both safety and immunogenicity, have been consistent throughout the studies with the same platform with the different formulations, and we expect that to be the case. So that is from internal data and then also public data and the data that CDC has presented as well.
Thank you. We'll move on to Dr. Talbot.
Yes, I think Grace alluded to this earlier. Pardon me, Dr. Lee. Can y'all please tell me what you are planning on charging so that we can view the cost effectiveness analysis in a more true light?
Yeah, definitely. This is Fran Pretty from Moderna. I'll just start off. So the list price for our vaccine is $129 per dose. Thank you.
Thank you, and thank you for being forthright.
So, can you hear me? This is Dr. Kane from Pfizer.
Yes, we can. Please go ahead.
Yes, the list price for Pfizer vaccine is $120 per dose.
Thank you.
John Truzino from Novavax.
Please go ahead.
So just a qualification, right? While we were not included in the model that Dr. Prosser presented, we do show our own pharmacoeconomic data that is consistent with that model, number one. Number two, the list and or WAC price that we refer to, ours is $130 per dose, which in industry conditions is subject to contract pricing and discounts. Also of note is that our contracted price with CDC is $72.50 per dose.
Thank you. I'm going to go back to Dr. Duchin. Thank you for your patience.
Thank you. Excellent questions. And this one may be for others besides the manufacturers, but I'm curious as to where we are in general with the issue of heterologous boosting. Dr. Sanchez alluded to this specifically with respect to the Novavax vaccine. Our NIH colleagues have presented to us at ACIP. Previously, there have been a number of publications that suggest superior immunogenicity with heterologous boosting. So I'd like to hear from our NIH colleagues or anyone else who can just summarize where we are with respect to the potential benefits of heterologous boosting at this point. Thank you.
This is John Beigel from the NIH. So we have done, as you've said, we've done heterologous boost trials, both mix and match the original heterologous boost, and then a subsequent where we did COVAIL, which was a boost on top of a mixed background. I would reframe the way you said it to say that heterologous boost shows it's just as good as a homologous boost. I don't think there's data to support that it is necessarily better, but in our opinion, that the data is fairly clear that heterologous boost is gives a good immune response similar to homologous.
And this is Philip from Novavax. We've done a number of studies looking at how our vaccine performs on top of a various number of platforms. And depending on the quality of the platform, it can make a difference. For the vaccines that are available in the US, I tend to agree with the NIH position that the immune response and magnitude is really comparable, irrespective of what the priming is. There are, however, different immunophenotypes that can be imprinted depending on which vaccine was given first. And that may turn out to make a difference in the future. We just don't have that data right now.
Thank you. And the last question goes to Dr. Daly.
Yeah, thanks so much. So I have two different points. I think I'll make these as comments and not ask for a response based on that we're running a little bit behind. I think the first is that I have heard from small private practices about a minimum order amount, something like 200 doses. And I just think that creates barriers. So I would ask all the manufacturers to consider reducing what the minimum amount that practices need to order, just because that's a significant financial outlay, maybe $20,000, and it's for a practice who might need to buy multiple doses for multiple different age ranges, for example, a small family medicine practice. And so then that just presents a barrier. So then I want to speak to this issue about where clinical data fits in. So I think we all need to keep in mind, and this is in some ways for the listening public too, that there is quite a bit of data in populations that might be adults, that might be children, that might be immunocompromised in these platforms that precedes all of this. And then the FDA working with VRBPAC makes a decision on strain selection, and they wait because they want it to be the most updated. And so then that leaves kind of limited time to produce that clinical data. Yet the other side of the argument is that the public would just like to know that this new strain selected has some clinical data behind it. So I think there's a tension there that we all need to recognize. And I think we need to take this back to the work group, have a discussion with our colleagues, including FDA colleagues and including manufacturers, to sort of figure out where that fits in. Because I think it's, at this point in the program, to me, it would be reassuring to have clinical data, but I recognize that it's a challenge because of the limited time frame. And we have all of this data of the prior formulations on which to make these decisions. Thank you.
Thank you. Dr. Trezino, we are at time. Do you have a really brief comment?
Yes, just to clarify our position on minimum order quantity, where, as Dr. Dubofsky said before, 10 doses and access through all nationwide distribution. So we are not limited in the equitable distribution of vaccine across the country.
Thank you. We appreciate that.
You're welcome.
Okay. With that, we're going to take a 5-minute break. Apologies to my colleagues, but I know some folks have things on the other end of the day. So 5 minutes and we'll return for our last session before public comment. Thank you. Okay, thank you, everyone. Sorry for the short break. We're going to go ahead and proceed with our next set of presentations. First, we'll have Dr. Megan Wallace presenting on the evidence to recommendations framework, followed by 2 other presentations. We'll then open it up for discussion. Just to confirm, Dr. Wallace, we can't hear you yet, which might be intentional.
Dr. Lee, can you hear me?
Now we can hear you. Thank you.
Perfect. Thank you. Next slide. Next slide. As you all know, we use the Evidence to Recommendation Framework, or ETR, as a structure to describe information considered in moving from evidence to ACIP vaccine recommendations and to provide transparency around the impact of additional factors on deliberations when considering a recommendation. Next. These are the ETR domains and questions. I want to remind you all that the COVID-19 workgroup decided that instead of considering equity as its own domain, we would acknowledge that it is a critical part of each of the other domains. Next. Therefore, we integrate equity-related questions into each of the ETR domains to ensure that all aspects of equity are adequately covered. Next. The policy question under consideration is, should 2023-2024 monovalent XBB-containing COVID-19 vaccines authorized under EUA or approved by BLA be recommended for use in persons 6 months of age and older? The products and ages currently authorized or approved by FDA include Moderna COVID-19 vaccine for ages 6 months and older and Pfizer-BioNTech COVID-19 vaccine for ages 6 months and older. Products and ages under review for authorization or approval by FDA include Novavax COVID-19 vaccine for ages 12 years and older. Next. This slide shows a visualization of bivalent COVID-19 mRNA vaccine recommendations. Under the bivalent recommendations, a multi-dose initial series is recommended in unvaccinated children ages 6 months to 4 or 5 years, depending on the manufacturer, with those ages 5 or 6 years and older, and those that are previously vaccinated all receiving a single bivalent dose. Next. The proposed recommendations for the 2023-2024 COVID-19 vaccine will be very similar to the bivalent recommendations, but with streamlining the multi-dose initial series to those 6 months to 4 years, with those 5 years and older recommended for a single dose of vaccine. Next. The current recommendations for the Novavax COVID-19 vaccine are narrower. The original Novavax COVID-19 vaccine remains authorized for use as a 2-dose primary series, and the original vaccine can be given as a booster dose in limited situations, which we've described here. Authorizations or approvals for the 2023-2024 Novavax COVID-19 vaccine will be determined by FDA with CDC recommendations to follow. Next. Just a quick note on the COVID-19 vaccine nomenclature. The updated COVID-19 vaccine is referred to as the 2023-2024 COVID-19 vaccine in this presentation. Following the ACIP meeting, both updated COVID-19 vaccine and 2023-2024 COVID-19 vaccine will be used to refer to the monovalent XBB.1.5 containing vaccines. Next. Now we will move to the public health problem. Next. These are the COVID-19 hospitalization rates, which you saw in Dr. Haber's presentation earlier. We see that hospitalization rates are highest in infants and older adults, and despite some recent upticks, the hospitalization rates overall are currently lower than what we've seen, what they've been at previous points in the pandemic. Next. However, when we look at the number of COVID-19 new hospital admissions by week from NHSN, we see that even when rates are low, as they currently are, that corresponds to over 17,000 new hospitalizations a week. Next. This slide shows the annual hospitalizations per 100,000 population for other pediatric vaccine preventable diseases prior to their vaccine recommendation compared to COVID-19. We see that the hospitalization burden is similar or greater for COVID-19 compared to the other vaccine preventable diseases. Next. We also have burden projections from the COVID-19 Scenario Modeling Hub. As a reminder, this is a multi-team effort aimed at creating and modeling planning scenarios of the mid to long-term COVID-19 situation. The policy scenarios are developed in close collaboration with government agencies and other stakeholders and project anticipated hospitalizations and deaths due to COVID-19. Next slide. For this round, there were 6 scenarios focusing on 3 vaccine recommendation scenarios and 2 different rates of immune escape. The 3 recommendation scenarios were no vaccine recommendation, recommendation for 65 years and older, and a universal recommendation. Additionally, there was a low immune escape and a high immune escape scenario. They assumed that vaccines were reformulated to target strains circulating on June 15th of each year, and that the vaccines were made available September 1st. The reformulated vaccines were assumed to have 65% VE against symptomatic infection with the strain targeted by reformulation. Vaccine uptake was based on first booster uptake, and teams were required to project a minimum of 2 years into the future. 8 teams provided national level projections. Some limitations of this work are that it can't fully account for new variants, and vaccine uptake and vaccine effectiveness may differ from the assumptions made. Next. Based on the ensemble projections, weekly hospitalizations are likely to increase this winter and stay within last year's range. However, the amount of immune escape and vaccine recommendations do impact the burden we will see, which we will get into a bit more in benefits and harms. Next. During our discussions, the work group asked to investigate if young people with no underlying conditions were still having severe illness from COVID-19. We know that underlying conditions put you at higher risk for severe COVID-19 outcomes, and that the percent of the population that has underlying conditions differs dramatically by age. To evaluate the burden among those without underlying conditions, we looked at the percent hospitalized for COVID-19 that have no underlying conditions by age group, which is the first column. And of those hospitalized with no underlying conditions, what percent were admitted to the ICU, which is the middle column. The final percent of those admitted to the ICU, and finally, what percent of those admitted to the ICU had no underlying conditions, which is the far right column. In each of these categories, we see that those without underlying conditions are progressing to severe illness, though we should note that these percentages should be interpreted with the understanding that children have a lower probability of having underlying conditions overall. I also want to mention that these findings of people ages 6 months to 49 years with no underlying conditions progressing to severe outcomes due to COVID-19 was confirmed in other CDC platforms. Next. On this slide, we're looking at the provisional COVID-19 deaths by week in the United States. Like hospitalization, the weekly deaths have been dropping since last winter and are currently at their lowest point. Next. This slide also shows COVID-19 deaths focused on ages 20 years and older by age group and year. Despite COVID-19 deaths being at their lowest point, the number of annual deaths is still very large. If you look at the red box, those are the provisional deaths through July 22nd of this year. Already this year, there have been over 400 deaths in those aged 20 to 44 years and thousands of deaths in the older age groups. Next. This slide shows the same data for the pediatric age groups, a population which is less likely to have underlying conditions and has had the lowest hospitalization rates overall. So far this year, we have already recorded 26 deaths in those less than a year old, 18 deaths in those 1 to 4 years old, and 36 deaths in those 5 to 19 years old. Last year, each of these age groups had more than 100 deaths. Next. When we considered the underlying condition status of pediatric COVID-19 deaths using data from COVIDNet, we found that COVID-19 deaths were rare among the pediatric population with no underlying conditions, with about 1% of hospitalizations in this population progressing to death, as is seen in the middle column here. However, when we consider pediatric COVID-19 deaths as a whole, as is seen in the far right column, 50% of those 17 years or younger that died of COVID-19 had no underlying conditions. Next. When we compare COVID-19 deaths to the number of deaths seen for other pediatric vaccine-preventable diseases prior to vaccine introduction, we see that in 2022, there were many more COVID-19 deaths compared to these other vaccine-preventable diseases. Next. And when we compare to the number of pediatric influenza deaths, we see that the number of COVID and flu deaths have been similar so far this year. And in previous years of the pandemic, COVID-19 deaths surpassed that of flu. Next. Now we'll discuss the domain equity question. Does the problem impact all populations equally? Next. This figure shows the recent COVID-19 associated hospitalization rates by race and ethnicity, with an age-adjusted 3-week moving rate on the left and cumulative rates on the right. As you can see, the cumulative hospitalization rates remain highest in American Indian and Alaska Native and Black persons. Next. This figure shows the risk ratio of death, invasive mechanical ventilation, and admission to intensive care unit by number of underlying conditions. We can see that for all outcomes, the risk increases with the number of underlying conditions. Next. This figure shows the prevalence of a subset of conditions with the strongest and most consistent evidence of association with increased risk for severe COVID-19 associated illness. As we can see, the prevalence of underlying conditions is not uniform across the United States, with the highest prevalence in the southeastern U.S. It is also worth noting that the prevalence of this subset of high-risk conditions is high overall. Next. This figure shows the number of chronic conditions by age among Asian, Black, Hispanic, and white adults in the National Health Interview Survey. Here we see that the percent with multiple underlying conditions increases with age and varies by race and ethnicity. Next. In summary, COVID-19 burden is currently lower than at previous points in the pandemic. However, the absolute number of hospitalizations and deaths is still high. Although hospitalization rates are currently low, we have seen rates increase in recent weeks and anticipate further increases as we enter respiratory virus season. Infants and older adults have the highest COVID-19 associated hospitalization rates. Children and adults with no underlying medical conditions still experience severe illness due to COVID-19. We saw in Dr. Sada's presentation earlier that post-COVID conditions are common following SARS-CoV-2 infection, decrease with time since infection, and have decreased since the start of the pandemic. People of racial and ethnic minority groups continue to be disproportionately impacted by COVID-19. High proportions of underlying conditions may put certain groups at increased risk for severe outcomes due to COVID-19. Next. When asked, is COVID-19 disease among persons 6 months and older of public health importance, the majority workgroup opinion was yes. Next. Now we will move to benefits and harms. Next. The available evidence include data from the 3 manufacturers, including clinical trial data from Moderna and preclinical data from Novavax and Pfizer. We have a great assessment of the benefits and harms of an updated COVID-19 vaccine. We also have data from post-authorization safety and effectiveness monitoring, which were described in presentations earlier today by Drs. Klein and Link-Gellis, detailing the intense and comprehensive safety and effectiveness monitoring of COVID-19 vaccines. As a reminder, millions of people in the United States have received COVID-19 vaccines under the most intense safety monitoring in U.S. history. We also have additional considerations, including a benefit risk assessment and modeling data. Next. Starting with the available data from COVID-19 vaccine manufacturers, Moderna provided clinical trial data from 101 patients randomized to receive a monovalent XBB.1.5 containing dose or a bivalent BA.4/5 and XBB.1.5 containing dose. Patients that received the monovalent XBB.1.5 containing dose demonstrated an increase in neutralizing antibodies with similar levels of neutralization across several XBB subvariants. Reported reactogenicity was similar to or lower than that reported from previous doses. Novavax provided preclinical data demonstrating that macaques boosted with XBB.1.5 showed an increased neutralizing response across several XBB pseudoviruses. And Pfizer provided preclinical data demonstrating that mice boosted with XBB.1.5 showed an increased neutralizing response across several XBB pseudoviruses. Next. The GRADE approach was applied to assess the type and quality of evidence for the anticipated benefits and harms of an updated COVID-19 vaccine. The PICO question and inclusion-exclusion criteria were intentionally narrow to best capture evidence most applicable to what can be anticipated from this year's vaccine dose in the U.S., including limiting evidence to U.S. studies of an updated vaccine formulation, in other words, the bivalent mRNA vaccines. 2 separate PICO questions were evaluated based on dosing cutoffs. The narrow criteria reduced the number of studies available in the body of evidence. However, this GRADE assessment builds upon a large body of evidence from the original monovalent vaccines. Next. For adolescents and adults, the components of the PICO question are shown on this slide. The population under consideration is persons ages 12 years and older. The intervention is 1 dose of an updated mRNA vaccine. The comparison is no updated vaccine. The workgroup identified the 6 outcomes listed here as the most important for the policy question. Next. And here's the PICO question for our pediatric age group, ages 6 months to 11 years. The workgroup identified the 7 outcomes listed here, which include all of the adult outcomes with the addition of MISC. Next. The importance and data sources available for evaluation of these outcomes are summarized here. Next. To identify relevant vaccine effectiveness studies, we used ongoing publicly available systematic review conducted by the International Vaccine Access Center, or IVAC, and the World Health Organization. We examined studies identified through June 29, 2023. More recent VE data were presented in Dr. Link Ellis's presentation. For observational data on vaccine safety, in consultation with the Immunization Safety Office, we included data from safety surveillance systems that have been presented to ACIP. To identify relevant randomized control trials, we relied on clinicaltrial.gov as the source. We included phase 1, 2, or 3 trials of COVID-19 vaccines, and we sought out additional resources, including obtaining unpublished data from the vaccine manufacturers. Next. A total of 6 observational studies were identified that met our inclusion criteria and addressed one or more of the PICO outcomes. We conducted a risk of bias assessment using the Newcastle-Ottawa scale, which assigns up to 9 points based on specific criteria related to selection, comparability, and assessment of outcome or ascertainment of exposure. Studies with a Newcastle-Ottawa scores less than 7 were considered to have serious study limitations. Next. For each outcome, we assessed the body of evidence for suitability of pooling. If multiple studies were conducted in the same population, the most representative study was selected. Meta-analyses were conducted using appropriate estimates from the remaining studies. Initial estimates were evaluated for heterogeneity. The pooled estimates were developed to summarize the estimates across several studies succinctly for grade and describe the best available real-world data for the policy question at this time. Next. For the important outcome of medically attended COVID-19, 2 studies were identified in the systematic review. This forest plot shows the VE estimate for each study. The pooled VE estimate from these studies was 53.1%. Next. For the outcome of medically attended COVID-19, we evaluated 2 observational studies. There was a risk ratio of 0.47. There were no serious concerns in the certainty assessment. Since evidence type starts at low for observational studies, despite there being no serious concerns, the final certainty was low. Next. For the outcome of hospitalization due to COVID-19, 4 studies containing 8 VE estimates appropriate for pooling were identified in the systematic review. This forest plot shows the VE estimates for each study. The top 2 estimates were from cohort studies. The following estimates are from case control studies at 7 to 59, 60 to 119, and 120 to 179 days following a bivalent dose and demonstrate waning of the vaccine effectiveness over time. A more comprehensive look at the impact of waning was given in Dr. Link Ellis's presentation. The pooled estimate across studies and time points was 47.8%. Next slide. For the grade assessment for the outcome of hospitalization due to COVID-19, we evaluated 4 observational studies with a pooled risk ratio of 0.52. There were no serious concerns in the certainty assessment. The final certainty assessment based on the observational data was low. Next. This forest plot shows the 2 VE estimates from observational studies for the outcome of death due to COVID-19. The pooled VE estimate from these studies was 60.5%. Next. For the outcome of death due to COVID-19, the pooled risk ratio was 0.39. There was serious concern for inconsistency as magnitude of effect and 95% confidence intervals from the 2 studies and the body of evidence varied widely, possibly reflecting differences in study methods. The final evidence type was very low. Next. For the outcome of post-COVID conditions, there were no studies that met the IVAC inclusion criteria. The common reasons for exclusion are listed on the slide. Although data were not formally included in grade, Dr. Seda gave a comprehensive review of what we know in her earlier presentation on post-COVID conditions. Next slide. For the critical outcome of serious adverse events, we examined 2 rare specific events, myocarditis and anaphylaxis, that have been associated with vaccination. For myocarditis, we evaluated an observational safety study from the Vaccine Safety Data Link, or VSD, which evaluated chart-reviewed cases of myocarditis occurring among adolescents and adults ages 12 to 39 years following a monovalent booster dose and bivalent booster doses based on events occurring in a 7-day interval after vaccination versus a comparison interval. Here we can see that rates of myocarditis and pericarditis varied by gender, age, vaccine product, and dose number. The highest rates were observed among younger males following the first booster dose of the original monovalent vaccine. While rates following a bivalent booster dose appear lower, they should be interpreted with caution due to a low number of doses captured in VSD and confidence intervals that overlap with the confidence intervals for risk following the monovalent booster. It's also important to note that myocarditis rates following a monovalent and bivalent boosters are lower than the rates observed following the primary series vaccination. Next slide. Regarding anaphylaxis, we examined data from VSD chart-reviewed cases of anaphylaxis among all vaccinated persons ages 12 years and older. Based on events occurring in a 0 to 1 day risk interval after vaccination, we estimated incidence of confirmed anaphylaxis among adolescents and adults was 4.8 per million doses of Pfizer-BioNTech and 5.1 per million doses of Moderna. There were fewer cases of anaphylaxis post-dose 2 compared with dose 1. Next slide. 2 specific rare SAEs have been associated with vaccination through safety surveillance. There were no serious concerns in the certainty assessment. The final evidence type was low certainty. Next. For the important outcome of reactogenicity, we examined grade 3 or 4 local and systemic events following either dose of the original COVID-19 monovalent primary series. This forest plot shows the pooled magnitude of effect for the outcome of grade 3 or 4 reactogenicity. Pooling the data from the randomized control trials, we estimated a relative risk for any grade 3 or 4 event after vaccination was 4.83. Next. There was very serious concern for indirectness as the available body of evidence did not include anyone who received an updated dose, was from a prior period of the pandemic, and excluded persons with prior COVID-19 infection, pregnant or breastfeeding women, and persons who are immunocompromised. The final evidence type was low certainty. Next. This table summarizes our current grade assessment for the updated COVID-19 vaccine in adolescents and adults. Next. Turning now to infants and children, we reviewed the observational data sources based on the pre-specified systematic review criteria, and the only study that was captured was one manufacturer's funded preprint among persons ages 6 years and older that studied a single vaccine. However, we can infer the benefit seen in adolescents and adults and downgrade for indirectness. The rationale for this inference is supported by the similarity in VE estimates across adult and pediatric age groups, which was presented by Dr. Lingelis. Here we see the pooled vaccine effectiveness findings against EDUC visits, hospitalization, and death that we just discussed in depth among adolescents and adults. The certainty for each of these outcomes in the pediatric population is downgraded for indirectness, which leads to a certainty of very low for all outcomes. Next. Turning now to harms in the infants and children. In the same previously mentioned analysis from VSD of myocarditis and pericarditis among children ages 5 to 11 years following a monovalent booster dose, there were 0 cases of myocarditis among roughly 50,000 males and 0 cases among 49,000 females receiving Pfizer. Next. And here we again see the rate of anaphylaxis in persons ages 12 and older, which can be used to infer the rate of anaphylaxis among children. Next. 2 specific rare SAEs have been associated with vaccination through safety surveillance. In the certainty assessment, there was serious concern for indirectness as the body of evidence for myocarditis was limited to children aged 5 to 11 years receiving a monovalent dose during an earlier period of the pandemic, and the body of evidence for anaphylaxis was among a different age group who again received monovalent doses during an earlier period of the pandemic. The final evidence type was low. Very low certainty, sorry. Next slide. This forest plot shows the magnitude of effect for the outcome of grade 3 or 4 reactogenicity. The top forest plot includes children ages 5 and 6 to 11, and the bottom forest plot includes children ages 6 months to 4 and 5 years. The difference in the magnitude of effect between the 2 age groups likely reflects the differences in systemic events captured and the inherent challenges in reporting reactogenicity among the youngest children. Therefore, pooled reactogenicity among the older age group was used for grade. Next. Pulling data from the 2 trials, we estimated a relative risk for any grade 3 or 4 event was 4.69. There were very serious concerns for indirectness as the available body of evidence did not include anyone who received an updated dose and excluded children who were immunocompromised. While children with a history of COVID-19 infection were included in the safety sets, the RCTs were conducted at a time of lower seroprevalence. The final evidence type was low certainty. Next. And here we have the summary of findings and evidence types in infants and children. Next. Regarding Novavax vaccine effectiveness and safety, due to the lower uptake of Novavax COVID-19 vaccines, no post-authorization vaccine effectiveness estimates from the prior COVID-19 vaccine formulation are available. Post-authorization safety data are also limited by the low number of doses administered. Available data from the Vaccine Adverse Event Reporting System, or VAERS, are consistent with those from pre-authorization clinical trials. Most VAERS reports were classified as non-serious. The most commonly reported adverse events included dizziness, fatigue, and headache. No new safety concerns were identified. Next. We conducted a benefit risk assessment for the updated COVID-19 vaccines. This figure shows estimated COVID-19 hospitalizations that would be prevented over 6 months per million updated mRNA COVID-19 doses among those aged 50 and younger. Those 65 years and older were not included to allow better visualization of the smaller estimates in these younger age groups. The blue bars represent benefits when hospitalization rates are similar to those from the spring, which had the lowest rates. Green represents rates from December 2022, the winter high, and gray are rates from summer 2022, which had the highest rates from the past year. One key takeaway is that the benefits are highly dependent on the hospitalization rates. But even with the lowest rates that we've seen, benefits of COVID-19 vaccination are anticipated in all age groups. For example, among those ages 6 months to 4 years, shown at the top of the figure, we estimate 103 to 476 hospitalizations per million doses would be prevented over a 6-month time period. Anticipated benefits are lowest in the 5 to 11 and 12 to 17-year-olds. Next. We also wanted to consider the potential myocarditis risk following updated COVID-19 vaccines in the age groups for which risk was observed following the primary series. There are limited data to inform the myocarditis risk following an updated mRNA dose. Myocarditis rates following a booster dose in adolescents and young adult males are lower than the rates following primary series, but estimates are limited by fewer number of doses for both the bivalent boosters and the previous monovalent boosters administered in VSD, which limits the precision for this rare outcome. Additionally, myocarditis risk is lower with the longer time between doses. We saw that rates of myocarditis were lower with an extended interval between dose 1 and dose 2 for the primary series. A longer interval between updated doses may also impact the myocarditis rates. Studies have shown that most individuals with pericarditis have fully recovered at follow-up, and in a study done earlier in the pandemic, the risk of adverse cardiac outcomes was notably higher after SARS-CoV-2 infection compared to after mRNA COVID-19 vaccine among young males. Next. On this slide, we are focusing on the adolescents, the group that had the highest risk for myocarditis following primary series and first booster. In addition to the hospitalizations prevented shown earlier, we've calculated that 5 to 19 ICU admissions and 0 to 1 deaths are anticipated to be prevented per million doses over 6 months. For both males and females, these benefits compare with 0 myocarditis cases and over 55,000 bivalent doses administered in VSD for each group. Next. This slide returns to the scenario modeling hub work, which was described earlier. Here we are looking at the cumulative difference in hospitalizations and deaths by vaccine recommendation scenario. If we focus on the red boxes, we see that a universal vaccine recommendation is projected to prevent about 400,000 hospitalizations and 40,000 deaths over the next 2 years, compared with no recommendation, regardless of the level of immune escape. Next. And here we see that compared with only vaccinating those 65 years and older, a universal vaccine recommendation is projected to prevent about 200,000 more hospitalizations and 15,000 more deaths over the next 2 years. Next. Now for the domain equity question. Are the desirable and undesirable anticipated effects demonstrated across all populations equally? Next. There are no evidence to suggest that COVID-19 vaccine effectiveness varies substantially by race or ethnicity. However, differences in vaccine hesitancy and uptake, crowding, access to care, and prior infection could impact vaccine effectiveness, and these factors may also differ by race and ethnicity. There is no evidence to suggest that COVID-19 vaccine safety profiles differ by race and ethnicity, but risk has been shown to differ by age and sex. Risk for myocarditis is highest in adolescent and young adult males. It is important to note that benefits and harms for the U.S. population are best assessed when clinical trial and study populations are optimally representative of the U.S. population. Next. In summary, monovalent XBB containing COVID-19 vaccines increase the immune response against the currently circulating variants. Last year's updated vaccine was effective at preventing medically attended COVID-19, hospitalizations due to COVID-19, and death due to COVID-19. Additionally, as you saw in Dr. Sada's presentation, there is accumulating evidence that COVID-19 vaccination reduces post-COVID conditions among both children and adults. COVID-19 vaccines have a high degree of safety. Rare events of myocarditis and anaphylaxis have been seen in post-authorization studies. It is unlikely that updating the formulation would increase adverse events. COVID-19 vaccine benefits are anticipated in all age groups, but the benefits of COVID-19 vaccines vary by age and incidence of COVID-19 hospitalizations. The benefits outweigh the risks in groups for which risk of myocarditis is highest. Modeling projects more hospitalizations and deaths are averted when updated doses are universally recommended compared to no recommendation or recommendation only for persons 65 years and older. Next slide. When the work group was asked how substantial are the desirable anticipated effects, the majority opinion was that the desirable anticipated effects were large, while a minority felt that it varies. Next. When asked how substantial are the undesirable anticipated effects, the work group felt that they are minimal or small. Next. Finally, when asked do the desirable effects outweigh the undesirable effects, the work group felt the balance favors the intervention, which is the 2023-2024 COVID-19 vaccine. Next. Now we'll move to the values domain. Next, thanks. This slide shows Americans' impression of the coronavirus situation in the U.S. over time. As you can see, the perception of whether things are getting better or worse has fluctuated throughout the pandemic, generally following changes in the infection rate. Over the last year, more Americans have consistently said that the coronavirus situation is getting better rather than worse. As of February, 62% said the situation was getting better, and 30% said it was staying the same, while just 8% said it was worsening. Next. Despite feeling that the COVID-19 situation was getting better, as of August, 30% of the U.S. adults report feeling very or moderately concerned about getting COVID-19. Next. Additionally, people still report concern about serious COVID-19 illness in their family. In March, 50% of people reported being very or somewhat concerned about a family member becoming seriously ill from COVID. Next. For equity, we considered if there is important variability in how patients or populations value the outcome. Next. This slide shows concern about getting COVID-19 by race and ethnicity. As you can see, there are differences in the level of concern by race and ethnicity, with white people having the highest percentage reporting that they are not at all concerned, while Black people have the highest percentage reporting that they are very concerned. Next. When considered by urbanicity, those living in urban areas reported more concern over getting COVID-19 than those in suburban or rural areas. Next. And when considered by income, concern about getting COVID-19 decreased as income increased. Next. In summary, as of February 2023, the majority of Americans felt COVID-19 was getting better. 30% of U.S. adults report that they are very or moderately concerned about getting COVID-19, and half of U.S. adults continue to have concerns about a family member becoming seriously ill from COVID-19. Racial and ethnic minority groups, those living in urban areas, and those with lower incomes are more concerned about getting COVID-19. Next. The majority of the work group felt that the target population feel that the desirable effects are moderate relative to undesirable effects, though a minority felt that it varies. Next. The majority of the work group felt that there was probably important uncertainty or variability in how much people value the main outcome. A minority of the work group felt that there was uncertainty or variability in how much people value the main outcome. Next. Now we'll move to acceptability of the intervention. Next. This slide shows intent to get a new, updated COVID-19 vaccine as of August. 42% of respondents reported that they definitely will or probably will get the COVID-19 vaccine this fall. Next. Based on data from the bivalent vaccine uptake and intent, we see that intent is highly related to receipt of previous COVID-19 vaccine doses. Those that had a past COVID-19 vaccination were more likely to have received a bivalent vaccine dose, while the majority of the unvaccinated reported that they probably or definitely will not get a bivalent vaccine dose. Next. And when we look at the top concerns or issues regarding the bivalent vaccine, among those that reported that they probably or definitely will not get the vaccine, regardless of past vaccination status, the most commonly reported concern was unknown serious side effects. Next. This slide shows reported confidence in vaccine safety for COVID-19 vaccine, influenza vaccine, and other routine vaccines. Confidence in vaccine safety is higher for influenza and other routine adult vaccines than for the COVID-19 vaccine, with only about half of respondents reporting that the COVID-19 vaccine is completely or very safe. Next. This slide shows the percent of individuals that were eligible to receive a vaccine that reported a vaccine recommendation by their healthcare provider. Although a majority report receiving a COVID-19 vaccine recommendation, this number is lower than what is reported for other vaccines. Next. And this provider recommendation seems to matter. On this slide, you see vaccine receipt by healthcare provider recommendation, and we see that those who received a provider recommendation were more likely to receive the recommended vaccine, and this is true across all vaccines. Next. Data from a fall 2022 doc-style survey were analyzed to examine the prevalence of COVID-19 vaccination attitudes and practices among healthcare providers caring for women of reproductive age, and to assess whether providers recommended and offered or administered the COVID-19 vaccines to their pregnant patients. Overall, 82.9% of providers reported recommending COVID-19 vaccination to women of reproductive age, and 54.7% offered or administered the vaccine in their practice. Among healthcare providers who cared for pregnant patients, obstetrician gynecologists were more likely to recommend the COVID-19 vaccine to pregnant patients than were family practitioners or internists. Healthcare providers were more likely to offer or administer COVID-19 vaccination on-site to pregnant patients if they also offered or administered influenza or Tdap vaccines. Next. Now we will consider if the intervention is equally acceptable across all populations. Next. This figure shows COVID-19 vaccine safety confidence by race and ethnicity. We see some variability here, with white non-Hispanic people having the largest percentage at either end of the spectrum, with 23% reporting they feel the vaccine is completely safe and 23% saying they feel it is not at all safe, while other racial and ethnic groups have larger percentages that fall in the middle. Next. When we look at perceptions of COVID-19 vaccine safety by income, we see that those with higher income report higher levels of confidence in the safety of COVID-19 vaccines. Next. There are also differences in confidence by urbanicity, with 30% of people living in rural areas reporting they feel the vaccine is not at all safe. Next. This slide shows fall vaccination intent by age group. We can see that the vaccine intent increases by age, with those ages 65 years and older being the most likely to report intent to vaccinate. This trend is also seen with other vaccines such as flu. Next. And this intent to get a fall COVID-19 vaccine mirrors the uptake we saw with the bivalent doses, with older adults having a much higher coverage than younger adults and children. Next. Intent to get a new updated COVID-19 vaccine varies some, but not substantially by race and ethnicity. Next. However, there continue to be disparities in receipt of COVID-19 vaccination by race and ethnicity, particularly receipt of a bivalent dose. Next. Like we saw in the overall population, healthcare provider recommendation is important across racial and ethnic groups, with those that receive a provider recommendation being more likely to receive a COVID-19 vaccine. Next. At the June ACIP meeting, we heard data regarding the risk of severe outcomes due to COVID-19 in pregnant people. This figure shows the percent of pregnant people ages 18 to 49 who are up to date with COVID-19 vaccines overall and by race and ethnicity. We can see that the percent that are up to date for all races and ethnicities depicted in yellow is low overall. There are also disparities by race and ethnicity, with Black and Hispanic pregnant people having the lowest vaccine uptake. Next. In summary, vaccine receipt varies by age and race and ethnicity. Fall vaccination intent increases with increasing age. Those ages 65 years and older have the highest percentage of vaccination intent compared to other age groups. Confidence in COVID-19 vaccine safety differs across the population. Compared to other vaccines, COVID-19 vaccines were recommended the least by healthcare providers, but those who received a provider recommendation overall and by race and ethnicity were more likely to receive the recommended vaccine. Encouraging healthcare providers to recommend, offer, and administer COVID-19 vaccines could help reinforce vaccine confidence and increase coverage. Next. When asked if the 2023-2024 COVID-19 vaccine was acceptable to key stakeholders, the majority of the work group felt that it varies, while a minority said yes or probably yes. Next. Now we will move to feasibility. Next. Vaccines with a monovalent XBB.1.5 composition will be the first COVID-19 vaccines to be available directly from the manufacturers as part of the commercial market, rather than through the United States government. While providers will no longer be required to report inventory to vaccines.gov after vaccines transition to being available on the commercial market, they will continue to be encouraged to report voluntarily. The public will continue to be directed to vaccines.gov to find providers offering COVID-19 vaccine. CDC will continue its efforts to make sure that all people have access to COVID-19 medical countermeasures and know where to find product now and in the future. Next. There are several important changes that will make vaccine implementation more feasible. Inclusion of COVID-19 vaccines and vaccines for children will likely result in more pediatricians stocking the vaccine. There will be single-dose vial presentations and smaller minimum order quantities. This directly addresses concerns from healthcare providers, is likely to reduce wastage, eases logistics, and helps with storage capacity limitations. I won't read through them all, but you can see the presentations and order quantities listed here. Finally, preparation is the same or simpler than it was before. Next. Storage and handling will be the same as it is now. Moderna is frozen until expiration in 30 days at refrigerator storage. Novavax is stable at refrigerator storage with a 9-month shelf life, and you must use it within 12 hours of first puncture. Pfizer has ultra-cold storage until expiration and 10 weeks of refrigerator storage. The ultra-cold storage continues to be a challenge as most provider offices do not have a unit. The dose volume for Pfizer is simplified. Now all doses are the same. And Moderna now only has 2 presentations, reducing the chance for errors. Next. There are still barriers to implementation. There are now 3 seasonal vaccines and preventative products, including COVID-19 vaccine, influenza vaccine, and RSV vaccine and preventative products, which means there are more vaccines to manage, limited storage space for more vaccines, and more opportunity for vaccine administration errors. Providers will need to adapt to new cap and label colors, and all 3 manufacturers now have products with blue caps, introducing opportunity for error. Next. Now we will discuss if the intervention is equally feasible to implement across all populations. Next. Now that COVID-19 vaccines have moved to the commercial market, there are disparities in uninsured status that could impact who gets the COVID-19 vaccine. Next. CDC will provide access to COVID-19 vaccines for uninsured individuals once COVID-19 vaccines become commercially available. Uninsured children will be able to receive COVID-19 vaccines through the existing Vaccines for Children program. The VFC program offers vaccines at no cost to eligible children through a national network of participating healthcare providers. Uninsured adults will be able to receive COVID-19 vaccines through a temporary program called the Bridge Access Program for COVID-19 vaccines and treatments. This program consists of 2 components. The first component utilizes existing public health infrastructure, including state immunization programs, local health departments, and HRSA-supported health centers to provide COVID-19 vaccines to uninsured adults. The second component will be implemented through contracts with pharmacy chains and will enable them to continue offering free COVID-19 vaccinations to the uninsured through their network or retail locations, as has been done during the COVID-19 public health emergency. Next. CDC's Bridge Access Program for COVID-19 vaccines and COVID-19 vaccine implementation plans are intentionally designed to overcome barriers to access and availability. This includes design for maximized proximity to no-cost COVID-19 vaccines among populations of people who are uninsured or underinsured. CDC and HHS continue to invest in health systems and programs that support vaccine access and outreach in underserved communities, such as HRSA-supported health centers, rural health clinics, and state and local health departments. These networks can be leveraged for access to COVID-19 vaccines as well as other needed medicines. Next. In summary, implementation of the 2023-2024 COVID-19 vaccine will likely reduce wastage, ease logistics, and help with storage capacity limitations and reduce the chance of errors. Nevertheless, there will now be 3 seasonal vaccines and preventative products for respiratory diseases, in which there will be more seasonal vaccines to manage, limited storage space due to these additional vaccines, and more opportunities for vaccine administration errors. Vaccines will continue to be accessible after commercialization with readily available resources for those who are uninsured and reside in underserved communities. Next. The work group felt that yes, the 2023-2024 COVID-19 vaccine was feasible to implement. Next. Now we will move to resource use. Next. You all saw Dr. Prosser's CEA presentation earlier today, but in summary, COVID-19 vaccination is a cost-effective intervention, particularly in persons ages 65 years and older in which the vaccine is cost-saving. Cost-effectiveness estimates in those ages 50 years and older were robust to input changes across plausible ranges. Cost-effectiveness estimates in those 18 to 49 years were sensitive to changes in inputs. If vaccine effectiveness or hospitalization rates are higher than anticipated, the cost-effectiveness estimates would be more favorable. Cost-effectiveness estimates are not yet available for the pediatric population. Next. For equity, we considered if the intervention is a reasonable and efficient allocation of resources across all populations. Next. COVID-19 vaccination is most cost-effective in older adults, in which disease burden is highest compared to younger adults. COVID-19 vaccination is likely more cost-effective in populations with risk factors, such as underlying conditions, which increase their probability of hospitalization due to COVID-19. Additional work is ongoing to evaluate cost-effectiveness in the pediatric populations. Next. When asked if the 2023-2024 COVID-19 vaccine is a reasonable and efficient allocation of resources, the majority opinion was yes, with a minority opinion of probably yes. Next. Now we will move to the summary and workgroup interpretations. Next. The burden of COVID-19 varies by age and underlying condition status, with those ages 65 years and older and those with multiple underlying conditions having the highest risk of severe outcomes due to COVID-19. COVID-19 burden is currently lower than at previous points in the pandemic. However, there are still thousands of hospitalizations and hundreds of deaths each week. Children and adults ages 5 to 49 years had the lowest hospitalization rates overall. However, severe outcomes still occur in this age group, including in people with no underlying medical conditions. Although hospitalization rates are currently low, we have seen rates increase in recent weeks and anticipate further increases as we enter respiratory virus season. The majority of the U.S. population has some level of immunity due to infection, vaccination, or both. Vaccine and infection-induced immunity wane and new variants have emerged, suggesting that susceptibility remains and may increase over time. Racial and ethnic minority groups have been disproportionately affected by COVID-19. Next. Monovalent XBB containing COVID-19 vaccines increase the immune response against the currently circulating variants. Last year's updated vaccine was effective at preventing medically attended COVID-19, hospitalization due to COVID-19, and death due to COVID-19. COVID-19 vaccines have a high degree of safety. It is unlikely that updating the formulation would increase adverse event rates. Benefits are anticipated in all age groups. Benefits of COVID-19 vaccines vary by age and incidence of COVID-19 hospitalizations. The benefits outweigh the risks in age groups for which there is myocarditis risk. Modeling projects more hospitalizations and deaths averted when updated doses are universally recommended compared to no recommendation or recommended only for persons 65 years and older. Next. The workgroup considered non-universal policy options with considerable discussion around the magnitude of benefits in the young, healthy population. As part of these deliberations, the workgroup requested additional data on severe illness due to COVID-19 in those with and without underlying conditions. There was no group that clearly had no risk of severe illness. Additionally, the vast majority of the U.S. population had an underlying condition that would qualify under a risk-based recommendation. Prevalence of overweight and obesity alone is over 70% in adults. A risk-based recommendation would not allow access to COVID-19 vaccines for all that wanted them. Shared clinical decision-making could create barriers to vaccination and may not effectively target those at highest risk. COVID-19 epidemiology remains uncertain, and non-universal recommendations would need to be quickly revisited if there was an increase in burden. There is currently still substantial COVID-19 disease burden, and simple, stable recommendations may increase vaccine coverage over time. The workgroup emphasized that COVID-19 recommendations should be reviewed on an ongoing basis as more is learned about COVID-19 seasonality and disease burden in the future. Next. The workgroup wanted to address COVID-19 vaccine recommendations in children specifically. Burden of severe illness due to COVID-19 is lowest among children ages 5 to 17 years. Despite lower burden relative to other age groups, hundreds of deaths due to COVID-19 occurred in this age group in 2021 and 2022. Half of pediatric COVID-19 deaths were in individuals with no underlying conditions. The number of COVID-19 associated hospitalizations and deaths in this age group are comparable to the burden seen in other vaccine preventable diseases for which there are universal recommendations. There are potential additional benefits of vaccination, such as prevention of post-COVID conditions and potential for reduced school absenteeism. Risk of myocarditis appears lower than the risk observed following the primary series doses, which may be due to the increased interval between doses. However, certainty is limited by relatively lower sample size of booster recipients in VSD. The future COVID-19 epidemiology remains uncertain, and the low disease burden we are currently seeing may not last. After a robust discussion, the workgroup was supportive of a universal recommendation at this time. Next. This slide shows a summary of the workgroups for each ETR domain. Next. For the balances of consequences, the majority of the workgroup felt that the desirable consequences probably outweigh the undesirable consequences in most settings, and a minority felt that the desirable consequences clearly outweigh undesirable consequences in most settings. Next. The work group recommended a universal recommendation for the 2023-2024 COVID-19 vaccine. Next. This slide shows the proposed vote language. ACIP recommends 2023-2024 monovalent XBB containing COVID-19 vaccines as authorized under emergency use authorization or approved by biologics license application in persons 6 months of age and older. Next. Before we move on, I want to present some brief clinical considerations. Next. This slide shows the proposed recommendations for mRNA vaccines. Everyone ages 5 years and older is recommended to receive 1 dose of a 2023-2024 COVID-19 vaccine. Children's ages 6 months to 4 years should complete a multi-dose initial series with at least 1 dose of the 2023-2024 COVID-19 vaccine. People who are moderately or severely immunocompromised should complete a 3-dose initial series with at least 1 dose of 2023-2024 COVID-19 vaccine and may receive 1 or more additional 2023-2024 COVID-19 vaccine doses. Bivalent mRNA COVID-19 vaccines are no longer recommended in the United States. Next. There are a few key changes in these recommendations compared to the bivalent recommendations. Previously, everyone ages 6 years and older was recommended for a single bivalent dose. This age has moved to 5 years for the 2023-2024 vaccine. This is because Moderna's age cutoff for the youngest pediatric group shifted from 6 months to 5 years, from 6 months to 5 years to 6 months to 4 years, which now aligns with the Pfizer age groups. This eliminates the complex recommendations that were previously in place for 5-year-olds. There were previously 2 Moderna dosages authorized for 6 months to 5 years. Now the dosages have been streamlined. All Moderna doses in ages 6 months to 11 years are now 25 micrograms, reducing the number of COVID-19 vaccine products in use. Finally, we had an optional second bivalent dose for those ages 65 years and older. We do not have an additional dose recommendation for the 2023-2024 vaccine at this time. We will monitor the epidemiology and vaccine effectiveness to determine if additional doses are needed. Next. In closing, I want to thank this incredible team that is responsible for the work I presented today. Next. Thank you.
Thank you for that very thorough presentation. Let me just confirm. Next, we'll move on to, so just as a reminder, I'm asking my members if they can please hold their questions, but collect them up because I know that was a lot of information. We're going to move on to the overview of COVID-19 vaccine implementation presentation by Dr. Georgina Peacock, and then one more after that, and then we will open it up for discussion and a motion. For Peacock, we can't hear you yet.
Okay, I'm here. Okay, thank you. Thanks, Dr. Lee. So I'm here today to talk to you about COVID-19 vaccination implementation, and I know you heard some of that now, so I'll briefly summarize some of the implementation that we're doing. Next slide. So COVID vaccine fits into CDC's overall fall respiratory virus vaccine program, and you'll see the program goals listed here: to protect Americans from influenza, COVID-19, and RSV, to promote vaccine uptake among those at highest risk, including older adults and those living in longer-term care facilities, people with underlying conditions, people who are pregnant, and children. Communication is really key to this, and communication new and rapidly changing recommendations for all three pathogens is really important. And then implementation, to make sure that implementation is equitable, including the Bridge Access Program for COVID-19 vaccines that you'll hear about a little bit later. Next slide. So before I talk about commercialization of COVID-19 vaccines, I want to recognize the tremendous efforts of many, including the multiple groups across sectors represented here today. So taking a moment to reflect that we completed yesterday 1,000 days of COVID vaccine delivery during the pandemic response, which resulted in over 1 billion vaccines distributed and almost 700 million doses administered. It's really a tremendous, tremendous accomplishment for everybody involved. So what will happen now with commercialization of COVID-19 vaccines? What will change is there will be a transition from federal procurement and distribution of all COVID-19 vaccines to a more traditional public and private model. There will be changes in the CDC COVID-19 provider agreements, and then vaccine data will transition to more routine reporting processes, and I'll talk about that in a little bit more in detail. So what won't change is the evidence-based vaccination program that develops recommendations, safety and effectiveness, and then also strengthens vaccine confidence, which you heard a lot about already today. And also CDC's commitment to ensuring access to COVID-19 vaccines at no cost for all Americans. Next slide. So here you'll see a snapshot of COVID-19 vaccine data reporting plans. And I won't go into all of the details, but if you look at some of the things featured here, you'll see that we will continue to get administration data from states. This will happen in an aggregate fashion, receiving monthly data. We also will get more detailed specific data on specific populations, such as pregnant people, people living in skilled nursing units, and be able to look at things like billing and claims data. The Bridge Access Program that you'll hear about more from Dr. Twentyman will also provide additional data for us on those vaccines that are being provided for uninsured adults. And then finally, we will have the information from the National Immunization Surveys, which will provide information on both vaccine coverage and vaccine intent. Next slide. An important part of implementation is having promotion and communication about vaccines. Next slide. So we have and here are some COVID-19 communications that will be part of those pan-respiratory efforts. Next slide. Here is a description of the different communication components and tactics. So we'll both have communications related to healthcare providers and then to consumers overall. So on the healthcare provider side, you'll see that there is different types of media, including social media and press releases, as well as earned media, different types of articles, and work with medical society partner outreach. On the consumer side, there will be similar items, and then there will be a concentrated consumer campaign related to the Bridge program. Next slide. And this just summarizes those different types of outreach activities that we will have. Next slide. So when I move into implementation, the first slide just reminds you, next slide, that you can find out about availability of COVID-19 and flu vaccines on vaccines.gov. And this week we will also be featuring, starting to feature where these vaccines are for the Bridge Access Program. Next slide. So the goal of our program is to ensure no-cost, timely access to COVID-19 vaccines for all. Next slide. So here we describe the availability of COVID vaccine, the federal contracts that have been modified in order to hasten delivery of the 2023-24 COVID-19 vaccines within our public health infrastructure for both children and adults will allow us to have the first doses available within 48 hours of the expected recommendation. There will also be the retail pharmacies that have been contracted to provide doses for uninsured Americans through the Bridge Access Program will also have availability within about that same time period, and we are expecting the commercial insurance commercial product will be expected around that same time frame as well. Next slide. So as we go through ensuring the access for the different populations, you'll see that when we consider access for those who have insurance, next slide, we expect that insurance plans will cover the 2023-24 COVID-19 vaccines immediately. So typically, the Affordable Care Act requires that insurers cover most ACIP recommended vaccines without cost sharing by the next coverage year. COVID-19 vaccines have been recommended on schedule since February 2023. However, in addition to this, for COVID-19 vaccines specifically, in the CARES Act, there was a statement that expedites coverage of COVID-19 vaccines so that they are available immediately upon authorization under EUA or approved under a BLA. And you can see the more detailed information right here. Next slide. So people with Medicare and Medicaid will also have access to COVID-19 vaccines at no cost. COVID-19 vaccines are covered under Medicare Part B without cost sharing, and the Inflation Reduction Act that was passed in August of 2022 eliminates cost sharing for all ACIP recommended vaccines under Medicaid and Medicare Part D equivalent plans, and guarantees that nearly 50 million Medicare beneficiaries and more than 80 million Medicaid beneficiaries will have access to all vaccines recommended by ACIP without cost sharing. Next slide. So as we move into talking about children, the Vaccines for Children program will cover all of those children that don't have private insurance that will pay for the vaccine. Of note, we are approaching our 30th anniversary for the Vaccines for Children program, and you can see some of the accomplishments of this program listed here. Next slide. As a reminder, the VFC program eligibility includes children 0 to 18 years that are either Medicaid eligible, uninsured, American Indian and Alaska Native, or underinsured. Next slide. And so this slide gives you some information about the reach of the Vaccines for Children program, and we do provide vaccinations for approximately 50% of those children in the United States, and COVID vaccine will remain available through Vaccines for Children providers. And so with that, I'm going to turn it now over to Dr. Twentyman to talk to us about the Bridge Access Program. Thanks.
Thank you so much, Dr. Peacock. Next slide, please. Good afternoon, all. My name is Evelyn Twentyman, and I serve as lead for the Bridge Access Program. Today, I'm going to be describing how CDC's Bridge Access Program is designed to protect no-cost access to COVID-19 vaccines for adults, including those who are uninsured and underinsured, and to maximize vaccine proximity, equity, and timely access for all. Next slide, please. Let's start with why this program is needed. As Dr. Peacock explained, this year's updated COVID-19 vaccines will be covered by insurance, and so access for many Americans will not change at all. Additionally, the Vaccines for Children's program will provide these vaccines to uninsured children. However, there are also 25 to 30 million adults without health insurance and additional adults whose insurance will not provide no-cost coverage following commercialization. There is not yet a permanent and comprehensive vaccines for adults program to ensure that adults have access to the vaccines recommended for them. And so we are standing up the Bridge Access Program as a temporary solution to maintain access to COVID-19 vaccines specifically in the short term. This program will begin as soon as vaccines have reached participating vaccine providers and will end by December 31st of 2024. Next slide, please. I'll now explain how this program is designed to maximize proximity to these vaccines. Next slide. Our analysis of proximity to COVID-19 vaccines among adults who are uninsured or underinsured found that about 39% of these adults were closer to a public health provider, such as our 317 enrolled providers, state and local health departments, and HRSA-supported health centers, as listed here, while about 61% were closer to a retail pharmacy, such as CVS, Walgreens, or a smaller pharmacy under the eTrue North umbrella. The Bridge Access Program is therefore designed to work through both these public health infrastructure and retail pharmacy components to maximize proximity of adults who are uninsured or underinsured to COVID-19 vaccines. Next slide. The Bridge Access Program COVID-19 vaccines will be available through local healthcare providers, including our 317 enrolled providers and health departments, through HRSA-supported health centers, and through participating retail pharmacies. Next slide, please. Here you'll see a slide containing all national proposed Bridge Access Program site locations. When both public health infrastructure and retail pharmacy components of the Bridge Access Program are included, you'll see that 85% of insured populations live less than 5 miles from a Bridge Access Program site, with particularly high proximity for urban populations. Unfortunately, 5% of uninsured populations are still estimated to be more than 10 miles away from a Bridge Access Program site, and efforts are ongoing to expand the Bridge Access Program footprint. Next slide, please. The retail pharmacies in the Bridge Access Program are using 3 different approaches to maximize access to COVID-19 vaccines. CVS plans to administer doses within both their storefronts and minute clinics. Walgreens plans to administer doses in both their storefronts and at offsite events targeting areas of low access and low uptake. eTrue North is a pharmacy aggregator that subcontracts with smaller pharmacies intended to reach lower access areas without other coverage within the Bridge Access Program. Their discussions with additional potentially participating pharmacies are ongoing. Next slide. I'm now going to speak briefly to how the Bridge Access Program is designed to maximize equity. Next slide, please. The Bridge Access Program is designed to address leading barriers to equitable COVID-19 vaccination, including in accessibility, availability, and confidence. We've already addressed how the Bridge Access Program helps overcome barriers to accessibility and availability. We also want to acknowledge threats to vaccine confidence and explain that to address these barriers, we are working to support and grow vaccine confidence through partnerships with trusted and welcome messengers to communities we serve. Next slide, please. This approach takes lessons learned from the uptake of the 2022-2023 bivalent boosters. We know that in order to reach populations in need of the bivalent booster, we needed to do more than communications campaigns and social media outreach, although these are important. We also needed to work with trusted messengers who were both believed in and welcomed by the people that we were trying to reach and could pair messaging with access to COVID-19 vaccines. Next slide. To this end, our community-based partnerships are key. The Bridge Access Program is supporting and working with numerous community-based organizations to undertake multiple activities to reduce barriers to vaccination and improve uptake, including hosting community outreach events, working within their communities as trusted and welcome messengers, partnering with providers to hold special vaccine clinics to provide greater access to vaccination, and to develop additional educational materials to promote COVID-19 vaccination within the Bridge Access Program. Next slide. Now I'm going to briefly turn back to depict the nature of the Bridge Access Program as a temporary solution to an important problem. Let's start on the left. With the creation of VFC about 30 years ago, the U.S. established a comprehensive pediatric immunization program which guaranteed universal access to all ACIP recommended childhood vaccinations to all children regardless of income or insurance status. This program has leveraged resources available under Section 317 of the Public Health Service Act to build and maintain the public health infrastructure necessary to implement quality immunization services nationwide, while using resources made available through VFC to guarantee access for the most vulnerable children. In contrast, the infrastructure necessary to ensure availability and access to recommended vaccinations for adults has not yet been well resourced, leaving substantial proportions of the U.S. population, adult population, that is unable to afford these basic life-saving preventive measures. The COVID-19 pandemic proved a stark illustration of why a comprehensive immunization program that supports the entire lifespan is essential to national emergency preparedness. This bridge access program for COVID-19 vaccines is a temporary and limited fix for a problem that can be permanently addressed by enactment of the Vaccines for Adults program proposal, which has been included in the President's FY24 budget. Coupled with Section 317 infrastructure resources, VFA could fill remaining gaps in adult immunization access and do for adults what VFC has done for children. Next slide, please. Before we close today, we want to leave you with resources that will be available for our partners, including several for people within the general public who would like to find vaccination through the Bridge Access Program or help others to do so. Please visit CDC's Bridge Access website for more information. Visit vaccines.gov later this week to find a Bridge Access Program site near you, and call 1-800-CDC-INFO with any questions. Next slide, please. Thanks so much, everyone. We want to particularly acknowledge the numerous public health practitioners and leaders across the Immunization Services Division, NCIRD, our interagency partners, and leadership and staff of state and local health public health programs on which our success in vaccination always depends. Thanks so much, everyone.
Thank you so much to all of our presenters. That was an incredible amount of information, a lot to process. And I'd like to open up this set of presentations for questions. As we're taking questions, I will also ask our colleagues at CDC to start to prepare to put up some vote language slides so that we can get a motion on the table.
Dr. Lee, we're having a technical challenge and cannot hear you in the room.
Oh, can others hear me? Is it just the CDC room?
I can hear you.
Okay.
I hear you.
Hold on. Well, I don't know if this is going to be a temporary or a permanent issue, but I do believe we're still recording. So let me just ask that if my colleagues have specific questions, since the room can't hear us, that maybe if you put your hand down and then raise it again, I will call on you and we can confirm the room is ready for questions. So Dr. Freihofer, I see your hand is up.
Yes, Sandra Freihofer, American Medical Association, speaking as a practicing internal medicine physician, and I'm not sure this is the exact time to ask this. But I'm seeing a lot of new infections in my practice consistent with waning protection. In fact, over the last couple of weeks, I've called in more Paxlovid than I have for the past 6 months. And so access to this updated vaccine is so timely and welcomed. And we heard today from the manufacturers about the studies showing cross-protective neutralizing antibodies against these emerging variants. But what do I tell these patients that have been recently infected and now recovered? When can they get the vaccine? Is there a recommended wait time between infection and getting vaccinated? I know in the past, CDC said to wait 3 months after infection, but does that still hold? And like I said, I don't know if this is the right time, but I certainly wanted to get this question in today because I can't wait to get this vaccine out to patients if it is approved by our ACIP today.
Hey, thanks for that question. Can everyone hear me okay?
Oh, we can hear you now.
Okay, wonderful. So you have the option to wait for 3 months, but it's not a requirement. So I think, as soon as they're feeling better, they can get the vaccine if they want it, but they can also choose to wait.
Thank you. I'm going to go back to Dr. Peeling.
All right. So first of all, I want to say a special thank you to Dr. Wallace, Dr. Peacock, and Dr. Twentyman for their great presentations and all the work that's going on to ensure access, equitable access across the country. I've got 2 questions, or a comment for Dr. Wallace and then a question. And in the presentation, it appeared that only about 20% of persons who were pregnant had received an updated COVID vaccine. And I thought that was really important because we saw that the children less than 6 months of age have hospitalization rates with COVID similar to that of adults 65 to 74 years of age. And the best protection that we can give the children is the COVID vaccine. In addition, it helps the moms in reducing prematurity. I wanted to confirm that data is still accurate.
Yes, that is accurate. I think we saw back in the June meeting that vaccination of pregnant mothers showed benefit to their infants.
Okay, and so this is a huge opportunity. And then my question is on clinical considerations. We talked about the complexity of the vials for pediatric offices. So many of them are now just using either Moderna or Pfizer. And so is there going to be a recommendation for offices where a child has received one dose of the opposite of what they carry? And how do they complete that dose now? Thank you.
Thank you. The authorization for the youngest kids, the 6 months to 4 years, is still a homologous authorization to complete that initial series. I think if you have that available to you, that's what would be recommended.
Thank you. We're going to go to Dr. Talbot.
This is a very brief comment. Those were fabulous presentations, which would not be necessary if we had vaccines for adults. So I'm just going to put my plug in for vaccine for adults. Thank you.
Thank you, Dr. Talbot. Dr. Sanchez.
Thank you. And, the presentations were really were excellent. And thank you, Dr. Freihofer, for bringing up the dosing, which I think that, I'm not sure how much booster somebody needs if they recently were infected with a recent COVID strain. But and maybe this should be later. Personally, I'm not sure that I'm for a universal recommendation. I certainly think that 65 and over should because of the data presented, and certainly other high-risk groups should. But I think the rest would be made, and I'm glad to discuss it further when when we get to vote. But I'm not yet convinced of a universal recommendation. Thank you.
Okay. Ms. Bata, why don't you go ahead?
Sorry, I've got a wild mouse here. Do we know, what can we anticipate in terms of vaccine availability? How many doses are we going to have? And maybe it's not relevant, but I'm curious.
We're not hearing any response from the room.
Sorry, we were waiting for the microphone. We don't expect to be supply constrained.
Do we have any idea of how many doses are in production for the season across at least the Pfizer and Moderna, since those are recently authorized? And maybe we can ask our
maybe the vaccine partner, the manufacturers are on the phone.
If you're still on the phone, please raise your hand because I can't see you right now. I'm going to let that question sit for a second because we're going to get through. There's a lot of hands raised, and I want to make sure we get a robust set of comments in before we look at the vote slide. Dr. Paling, sorry.
May I ask for the voting language slide to be put up? I was convinced about the importance. I recognize that long COVID is a big deal and is the risk goes down with COVID vaccine. And we also know MISC is a big deal in children. And we also know that there are many children that get hospitalized and into the ICU, and there is no risk factor. So for me, the best prevention is vaccine. And if the slides are up, I would like to make a motion. Thank you. And so I'd like to make a motion to accept the language as written. Thank you.
Thank you. Dr. Wallace, did you want to go ahead and read this slide out just in case so people can hear the language?
Yes, thanks, Grace. ACIP recommends the 2023-2024 monovalent XBB containing COVID-19 vaccines as authorized under emergency use authorization or approved by biologics license application in persons 6 months of age and older.
Thank you. Back to Ms. Bata, and then I see Dr. Pretty on the phone, has raised her hand. So Ms. Bata?
I will second that motion.
Okay, thank you. We're gonna pause for a second. Well, let me just say it's been moved and seconded that the proposed ACIP voting language that is listed on the slide and described by Dr. Wallace be the proposed vote for after public comment. I'm gonna go to Dr. Pretty next.
Oh, thank you. I just wanted to respond to the last question about supply. We predict that we'll have adequate supply. We don't anticipate there'll be any restrictions, and we're happy to give an official number offline. We can get that. Thank you.
Okay, thank you for responding. Dr. Long.
Sorry, take me a while. So so now we're discussing the real meat of this proposed language. Do I understand from this that this would include Moderna, Pfizer, and potentially Novavax without us discussing Novavax again?
Yeah, so the vote today would be Moderna and Pfizer because those are the two with products under emergency use authorization or approved by biologics application. But it would mean that we probably would not meet again for Novavax, though all of the available data have already been presented today.
So that really is a departure. I'm really very concerned about that. On one hand, we certainly want children 6 months of age and older, especially those young ones, to have the opportunity to receive this vaccine. And we certainly want vaccines other than a messenger RNA vaccine to be available. But the lack of data in children and lack of any clinical data in children and lack of data, in total, makes me concerned about particularly Novavax, which is adjuvanted, and I have not heard anything about this adjuvant from the work group. So I wonder if if Matt Daly could say something about, I don't want to hear more from the manufacturers. Sorry, incidentally, the Novavax killed my email today. More than 300, please confirm Novavax. That's unprecedented for any of the other vaccines, and it doesn't actually help us. It makes it more difficult for us to do the good jobs we do when we're not on this call. So let's please stop that kind of activity. But I wonder, Dr. Daly, if you could tell us why you thought we could do this without further discussion.
Well, actually, I'm just going to jump in, Dr. Long. Just to clarify, I just want to, my understanding from what Novavax presented is it would be for 12 and older is what is anticipated. So while this recommendation is to ensure consistency on the general recommendation with products that are available, I don't believe that necessarily means that there would be a brand new recommendation down to 6 months for a vaccine that hasn't been previously authorized or approved. But I'm happy to defer to my colleagues at the CDC and the FDA. And Dr. Daly, if you wish to respond, please feel free.
Well, I'm gonna respond in brief. Dr. Long, thanks very much for the question. Novavax has presented multiple times before the ACIP COVID vaccines work group. But in terms of public ACIP meeting, we're restricted to review and vote on the vaccines that have an EUA and have a BLA. And then the decision about whether to have another public meeting when Novavax receives approval from the FDA. I mean, I think that's not a work group decision. That's, you know, ACIP secretary, ACIP chair decision. So I think at that point, I'll ask for them to comment. Thank you.
Dr. Wharton.
Dr. Lee, this is Melinda Wharton. So the vote.
We just lost you, Dr. Wharton.
We're using a hand mic in the room and we're all having trouble with it. So the vote language as proposed, the intent of it is to cover for the upcoming season the XBB containing monovalent vaccines as they are authorized either under emergency use authorization or approved by BLA. There is, as has been discussed today, one product which according to the manufacturer remains under review and we anticipate will likely be authorized soon. The available information has been presented today. As far as I know, no additional information will be available that would be able to be presented at an upcoming meeting following regulatory action. So we certainly could reconvene the meeting. We always can reconvene ACIP if it feels necessary, but given the fact that no additional information is expected to be available, it feels like this is the kind of vote that we can move to a more normal cadence of things, such as we do for recommendations like for influenza vaccine, where we don't necessarily need to reconvene the committee when additional products are licensed under existing recommendations.
I would like to just follow up, Dr. Wharton and Dr. Lee, to understand that if FDA does not authorize Novavax for 6 months of age and older, that this will not be applied at, it says 6 months of age and older. And I would be very firmly against such a recommendation.
It would be recommended as authorized, and our expectation is that we be authorized for 12 years of age and older.
Thank you. That's all I wanted to know.
Thank you. All right, I'm going to go to Dr. Duchin.
Thank you. Yes, I wanted to just follow up on the vaccine for adults discussion, which was incredibly valuable. Thank you, Dr. Twentyman. You know, with tens of millions of underinsured adults who don't have access to the disease and life-saving vaccines that the rest of us have access to, we really have a huge problem in the U.S. This represents a burden of preventable illnesses, hospitalizations, and deaths that we really shouldn't be tolerating. So I want to re-emphasize on behalf of the Infectious Disease Society of America, on behalf of the National Association of County and City Health Officials, that we need a vaccine for adults program. It's essential. And one of the things I'm curious about is whether we can see in the future a cost-benefit or analysis or a cost-effectiveness analysis about what we would gain with respect to prevented morbidity, mortality, and cost, and maybe at some point in a future meeting. For this meeting, one question I have with respect to the BRIDGE program, where does the public get information on where vaccines for uninsured people will be available in their communities? Is there a centralized place where they can go to get that info?
Thanks so much, Dr. Duchin. There is indeed. Later this week, vaccines.gov will be updated to include a filter for Bridge Access Program site. In other words, all sites participating in the Bridge Access Program through which no-cost COVID-19 vaccines can be found. Thank you so much.
Wonderful.
Thank you. Dr. Cieslak?
Hi, thanks very much. I agree with what Dr. Duchin just said. I guess I just have a comment, and that is that I'm struck by the number of unknowns and the low certainty and very low certainty evidence regarding both efficacy and reactogenicity that were presented, along with widely varying estimates of risk by age and underlying condition. That I'm surprised at the recommendation for a universal recommendation. I would think that a shared clinical decision-making recommendation for most groups would be more consistent with the state of the science at this point in time. Thank you.
Hi, this is Dr. Wallace. If I could just offer some clarifying remarks. Whenever grade is applied to observational data, the evidence certainty always starts at low certainty. So whenever these vaccines were all first graded back, whenever they did the large RCTs with the monovalent, those were all high certainty data because they started as RCTs. So part of the grade interpretation has to do with the fact that we are now looking at observational data instead of randomized control trials.
Thank you. We're gonna move to Dr. Rockwell.
Hi, thank you. Pamela Rockwell, family physician representing American Academy of Family Physicians. My question is about clinical guidance, just anticipating questions I'll get from my patients. If somebody received the bivalent shot within a week or 2 weeks, what do I tell them about getting this new 2023-2024 vaccine?
We're recommending a 2-month interval. So 2 months from your past dose, you can get this vaccine.
Thank you so much.
Dr. Fiskus.
Hi, thank you. I'm Michelle Fiskus. I'm representing the Association of Immunization Managers. I have a question, maybe Dr. Peacock can answer, it might need CMS. If an individual covered by Medicare is going to get co-administered RSV, COVID, and flu vaccines, do we know if it will be permitted for that provider to bill both Medicare Part B and Part D on the same day? And also if Moderna can comment on when the pediatric vaccine will be available from Moderna. Thank you.
Hi, thank you, Dr. Fiskus. I think we have our CMS liaison on the line, and they'd be better to answer that. Thanks. We'll get back to you on that. Thanks.
Would you like me to respond for Moderna?
Sure, go ahead, Dr. Priddy.
Okay, hi, it's Fran Priddy. Yes, so we've tested our vaccine, our prior versions in children, as I mentioned before, and are in the process of accumulating the required safety follow-up needed to file for licensure. And we anticipate doing that in the first part of 2024.
Okay, thank you. Dr. Fiskus will ask if our CMS colleague can comment later, but for the next three hands raised, I'm just going to ask our ACIP members if you could provide any comment, ask any questions you have, but also please give us your thoughts around the proposed ACIP voting language on the table, just so we can make sure we have a robust discussion around this. Dr. Lair.
Thank you. My question is regarding immunocompromised people. We currently have a recommendation that they can get a booster dose 2 months after they get the dose. Have the people writing the clinical considerations given any thought to what they're going to recommend going forward with immunocompromised people?
Hi, this is Dr. Wallace. So our planned clinical considerations for persons with immunocompromising conditions will be really similar to what they are for the bivalent dose. They will just be traded out. So if it's an immunocompromised person that has not been vaccinated, they will they'll be eligible for an initial COVID-19 vaccine series. For those that have previously completed an initial series, they're recommended for at least one 2023-2024 COVID-19 vaccine dose, and they may receive one or more additional doses as well.
And just to clarify, the prior recommendations for immunocompromised still stand under this recommendation?
Yes, we'll just be switching out the formulation.
Oh, I see. Okay, the last bullet. Thank you. Dr. Lair, did you have another question or comment?
No, thank you.
Okay, thank you. Dr. Brooks?
Yes, thank you. First of all, excellent presentations, the ETR and Dr. Peacock and Dr. Twyman. Thank you, Dr. Wallace. I think we have all the information that is available. So this is what we have to make the decision. I put on more of an influenza hat because though this is the first year, there's the potential that we'll be doing this every year in terms of evaluating a new vaccine or the concept of a new COVID-19 vaccine. So when we do influenza, we don't review it every year and look for all the data that we're talking about. This is what we have. We have a major illness. We have to do something. I'm fully in favor of it, of the universal recommendation. I think that the long COVID data for post-COVID conditions is compelling. And we don't have a lot of data in the children, but in terms of universal, it's likely it'll be a benefit. Feel good about the fact that in the bivalent, we saw no signal for myocarditis, very important. In terms of equity, African Americans, even from younger ages, have higher incidence of underlying conditions, which would lead to higher adverse events in terms of hospitalization, ICU, and death. So definitely the vaccine needed. And lastly, the lowest recommendation rate from healthcare professionals to get a COVID vaccine. So that's something that we need to work on. But in the end, this is the information we have. The virus is out there, is mutating. We saw data from at least one of the vaccines that shows that they have neutralizing antibodies against the XBB 2.86. So fully in favor of a universal recommendation.
Thank you, Dr. Brooks. Dr. Sanchez.
Yes, just wanted to add some comments here. I'm not for a universal recommendation at this time. I certainly think that those the elderly adults, whether 65 or greater than 55, I would recommend that, as well as certain risk groups, certainly the immunocompromised in pregnancy. But I think that we need to be aware and let the public know that the data on children is not there. And for that, I think that discussion needs to be had. So I think in non-high risk groups, I would favor a shared decision making, and even the concern for the 12 or 15 to 39-year-old, the myocarditis risk. I recognize that it hasn't been seen with the bivalent dosing, but the uptake has been low for that as well. So I think we need to be, we really need to level with our patients and say what is known and unknown rather than make a complete recommendation, especially for some groups that there are limited data. Thank you.
Thank you, Dr. Daly.
Yeah, thanks so much. I think I have a couple of comments, but I'm going to try to directly address Dr. Sanchez's comment about sort of the amount of data. I think this is a complex and subtle point, but I think we have quite a bit of data, including quite a bit of data about the use of these vaccines within kids, but then that data is based on prior monovalent and prior bivalent. So it's not a total absence of data. When we say limited data, it's limited data of XBB.1.5 as a strain. So I think that's a little bit more, I realize it's complicated, but I want to make that point. So a couple important points of context I want to provide. First, as our colleague Dr. Talbot's mentioned at prior ACIP meetings, once a vaccine is universally recommended on the schedule, it's difficult to change that policy decision. So I appreciate that. I want to mention that. Second, based on some feedback that we've received, there was some concern that the work group entered its deliberations this summer, assuming that a universal vaccination strategy was the obvious policy choice. But I just want to reiterate that that was very much not the case. The work group reviewed this as an opportunity to reevaluate the vaccination program, and we essentially started with a blank slate. And so related, the work group asked our CDC colleagues to update and present data on disease burden by age group for those with and without chronic medical conditions. And that was the most persuasive line of argument for me, knowing that there were deaths, including in children, including in those without chronic conditions. And my perception is that those deaths are vaccine preventable. And when we asked for this burden data, the focus was on serious disease, including hospitalization, ICU admission, and death. And Dr. Wallace summarized all this for us. And suffice it to say that the disease burden does vary greatly by age, but there is serious illness, death across all age groups, including among those without underlying medical conditions. So there may be a day where we revisit a risk-based strategy. We always should consider this. But in order for that to be a desirable approach, I think we need to feel confident that disease burden in those not at risk would need to be quite low. And that's low in absolute terms of cases of serious illness and death, but also low in relative terms, relative to the burden of disease for other diseases against which we have a universal vaccine recommendation. Thanks.
Thank you, Dr. Daly. Dr. Sineas?
Thank you. I just wanted to say that I agree with a universal recommendation for all the reasons that Dr. Brooks listed, in particular in the realm of equity. I just do not feel that a shared decision making recommendation promotes equity. I feel like it would lead to more disparities. So I'm in favor of the voting language as it stands. Thank you.
Dr. Bell?
Yes, thank you. I just wanted to sort of, add in my perspective. I agree with what Dr. Daly in particular said, and I just want to first of all say that, my responsibility, my job is to give the best advice given the current data and circumstances, and so that's what I'm trying to do. I think today we've heard a wealth of evidence about the risks, the benefits, extremely comprehensive dealing with the issue. And to Dr. Daly's point, I think that it indicates there's all kinds of robust information that show robust benefits of vaccination on severe illness, on death, probably on long COVID. And so with a reasonable safety profile, granted not exactly with this vaccine, but with, a very, very similar vaccine. So I think that it's clear that vaccination is going to prevent serious illness and death across all age groups. It is a vaccine preventable disease. And so I, for that reason, favor universal recommendation. Now, having said that, because I think it's important for people to have access to the vaccine if they want it. Having said that, I also want to say that there's not equal risk across all ages and populations. And it's clear that there are certain people, like old people like me, people with underlying medical conditions, that are at much higher risk of dying. And so I think that the messaging needs to sort of clarify that and make clear that that there is this differential risk and that a lot of people with underlying medical conditions and who are older are dying, and they really need to get a booster. And then the last thing I'd like to say is about the equity issue that Dr. Sine has just raised. And I agree with her that shared clinical decision-making does not promote equity. And I also want to congratulate the CDC on the BRIDGE program and these efforts to sort of deal with the fact that we don't have a vaccines for adults program. But I think that we have to continue to work hard day after day, not just the ACIP with our recommendations, but everybody who's working in this space to continue to promote equity, because we continue to see that these disparities continue to exist and are perpetuated. And we just really, I think that is just such a high priority. I wanted to just make that point again. Thank you.
Thank you. Dr. Long.
Yes, I've been very grateful for Dr. Daly and Dr. Bell's insights and sage advice. And I was going to want to go down the path of risk-based because I am concerned mainly that if you just recommend it universally, it's as if game as usual, when we really want to emphasize those who are at risk of death. And I was thinking maybe the best way to do that would be to be risk-based with a permissive for everybody else. And I suspect that Dr. Bell thinks this would work better to recommend it for all. and then somehow be sure that the group who really is at risk of high risk of death, the elderly, the obese, those with underlying conditions, those who are immunocompromised, and children to 6 months to 2 years, and by extension, under 6 months, whose mothers need to be. I'm not still quite sure how the best way to get our best intentions implemented into action and for people to take up the vaccine. So I'm swaying toward thinking universal may be the best we have, but it's not good enough, because I think we'll recommend it and nobody will get it, or the people who need it most may not get it, and especially the groups for whom we're concerned about equity. Thank you.
Thank you, Dr. Nelson. I mean, Dr. Cotton. I always do that to you. Sorry, Dr. Cotton.
Thank you. As a very active adult infectious disease specialist who sees many patients, inpatients and outpatients, I have been astonished at the number of people who have not been vaccinated. We need to make vaccination recommendations as clear as possible. Shared clinical decision-making will result in major problems with equity, and I'm strongly in favor of a universal recommendation providing clarity and hopefully confidence in the CDC and other US government bodies, including the FDA. But let's keep America strong, healthy. Let's do away with COVID-19 as best we can by prevention of disease through vaccines. Let's make things clear. That's my vote. Thank you.
Thank you. I'm going to go to Dr. Lair.
Thank you. I have immense respect for Dr. Sanchez's position, and I understand where he's coming from because I'm often hesitant about universal recommendations. But in this case, I'm very strongly in favor of it. I'm impressed that the work group reviewed the data from scratch. I'm impressed with the economic benefits. I feel that the overwhelming benefits of recommending it for everybody and making it a simple recommendation will outweigh the complications that would happen with shared decision-making or risk-based recommendations. So I too am in favor of the universal recommendation. Thank you.
Dr. Wharton?
Dr. Mann would like to make a comment about communication strategies.
Yeah, thanks so much. And sorry, this is in response to Dr. Long, and I'm sorry we had a little trouble putting our hand up. But I just wanted to say that very mindful of the groups that are at substantially higher risk and are planning targeted communications to try to have vigorous and compelling outreach to those groups. That can be done regardless of whether a recommendation is targeted or not. So under a universal recommendation, we will still have targeted communications for older adults, immunocompromised persons, and others at higher risk. Thanks.
Thank you, Dr. Hopkins.
Thank you, Dr. Lee. And I want to thank, on behalf of NFID, I want to thank ACIP for its diligent work to ensure the availability of these safe and effective vaccines. I think our challenges of communication and of getting these vaccines into arms and protecting our adults and children in our society are going to be important as we move forward through these recommendations. Although the rates of hospitalization and death due to COVID-19 remain low compared to pandemic levels, certainly COVID-19 remains a significant public health problem, and transmission is increasing with the recent emergence of the different variants. As this new monovalent vaccine becomes available this fall, it'll be essential for all of us to work collaboratively and collectively to increase immunization rates and reduce the burden of disease, and also to be responsive to questions and concerns about the multiple different respiratory virus vaccines we're going to need to use. You know, our respiratory seasons are notoriously unpredictable. And while it's not possible to predict the severity of this upcoming season, we do know that planning and preparation are critical, as are the right messages and messengers to strongly encourage folks to provide clear guidance on vaccine timing and on the public health messaging. And again, I thank you for your time, and NFID will continue to partner as we close our 50th year and continue to move forward in support of better public health through vaccination in the future. Thank you.
Thank you. Dr. Freihofer, did you have a quick comment?
Yes, I just wanted to point out that in Dr. Wallace's slide 22, half of the children who died had no underlying conditions. There is no group that clearly has no risk from COVID. And even children and adults with no underlying conditions can still experience severe illness due to COVID. And we're at a point now when vaccine and infection-induced immunity is beginning to wane. We have these new variants that are emerging. We're all becoming more susceptible. This will likely increase in time, and we're sort of seeing that. This new vaccine will increase the immune response against circulating variants. Today's discussion makes me very confident of that. This new vaccine will help protect us from COVID, and I really encourage ACIP to vote for a universal recommendation for those 6 months and older.
Okay, thank you. I just have one last comment I just wanted to express as a member. So I also feel, reviewing the data today, that the benefit-risk balance makes sense for people 6 months and older, with the greatest benefits in the oldest and the youngest. So then for me, you know, much of the decision from there rests on cost effectiveness, implementation, and equity issues. And I'm just going to highlight a couple of equity issues that I think are important to highlight. So on the equity front, first, our healthcare delivery system in the US continues to have structural inequity built into it that functionally makes access to care more difficult for some compared to others. And I believe this is different from the situation in other countries where healthcare coverage is universal. Second, our vaccine financing system, which is a public-private partnership, inherently relies on healthcare providers and some in small practices to carry the financial burden of vaccine purchase without assurances that they'll be able to be fully reimbursed for their costs or for doses that go unused in multi-dose vials. So there is risk to providers delivering these vaccines, despite the immense benefit they can provide to our patients. So if we make complex and nuanced recommendations, I believe we're adding burden to our health systems and to our providers, which in turn I think will unintentionally add to existing inequities. So I really wanted to strongly endorse the universal recommendation for that reason. I also want to recognize and laud CDC for doing everything within their power to ensure that these gaps are minimized, and doing this well in advance of a recommendation. Is not a long-term or sustainable solution, and certainly not one that can extend to other critical vaccines that we also need to protect our patients and families. But, you know, I recognize this is not a problem we're going to be able to solve, but I do think that we are making the decision today for the US, given the context that we're in. Other countries might end up making different decisions because their context differs entirely. But because access to vaccines is so critical and there continue to be disparities, I feel strongly a universal recommendation is indicated. And with that, I'm going to give our team just a 3-minute break. So we'll meet at 45 minutes after the hour. Come back for public comment, and then we'll move into the vote shortly after that. Thank you, everyone. Thank you, everyone. I'm going to move us along and thank our public comment speakers for joining us today. We're about to begin oral public comment. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period. In order to make it through all the listed speakers, we ask that each speaker limits his, her, or their remarks to 3 minutes. We do have a timer displayed on the screen so you know how much time you have left. I also want to just highlight that while we had, well over 130 people who requested to speak, I don't know if we went long over or what happened, but we have one public comment speaker with us today, and we very much look forward to your comments. So I invite Dr. Melanie Matthew to please go ahead and provide public comment.
Hi, thank you so much. Good afternoon. My name is Dr. Melanie Matthew. I've published and worked in the field of immunology for over 2 decades. Very quickly, for disclosure purposes, I am a founder of a company, but there's no financial interest in the outcome of the decisions made today by ACIP. For the last 3 years, I've used social media to teach about the SARS-CoV-2 virus, vaccinations, variants, and communicate many of your guidelines to hundreds of thousands of people. So I'm delighted to be here today, and I'm very heartened to hear all of the recommendations for universal vaccine rollout. That is what I'm here to talk about. I really feel strongly that all people of all age groups for which the FDA has approved this vaccine have access to this vaccine. There's been a lot of discussion about children today, and I understand that the data pool is not what we would hope for there. However, children, although they do suffer from less COVID-19 morbidity and mortality, there are numerous examples of lifelong morbidities associated with SARS-CoV-2 infection in children, including higher rates of higher rates of new onset type 1 diabetes, and numerous case studies showing significant cardiac issues, including necessitating pacemakers being placed in previously healthy children, all post-SARS-CoV-2 infection. And as long as this vaccine is deemed safe, I do not understand why it would be withheld from that population when it could have a significant impact on lifelong morbidity and allow a child to live a healthy life. We also tend to forget that children do not live in a bubble. They're often part of multi-generational households. They see teachers daily, and protecting children from significant bouts of infection and reducing duration of infection also protects people writ large. I'll make 2 more brief comments. I actually don't see the timer, so feel free to cut me off. But COVID-19 more sequelae is significant, and it's correlated with severity of disease. And severity of disease, we know well, is reduced by vaccination. Post-acute sequelae from SARS-CoV-2 also shows up not after first and second infections, but often after third, fourth, and fifth infections. There is literature evidence that damage accumulated from SARS-CoV-2 infections is cumulative with each infection. So although many people have been exposed to viral antigens through vaccination, infection, or both, you can see physical damage being cumulative in the population, and increased mortality 6 months out has been also demonstrated in the literature. So we do know that vaccine protection wanes and can be significantly eroded by changes in the spike protein.
15
so
seconds.
Again, oh, sorry, am I over?
Just 10 more seconds. Please go ahead.
10 more seconds. All right. Well, thank you so much. I just wanted to say that I think it's abundantly clear that we need updated vaccines on a yearly basis at a minimum. And it would be unprecedented to restrict access to an approved vaccine that limits potential lifelong illness and disability.
Thank you for your comment. Appreciate it. I'm sorry you could not see the clock. We will I would just want to thank our public comment speaker, and also thank those who take the time to submit written public comments via the CDC docket. We had over 15,000 written submissions, and certainly have heard the voices of the public on the issues at hand. With that, we are going to move to our vote section of the meeting. So I'm going to ask our colleagues in the room to please put up the proposed ACIP voting language that is up for vote. So any other questions, clarification, comments people would like to make before proceeding with the vote. And I will remind my colleagues that we do need to put our screens on for the vote. Yeah, I don't see any hands raised, but I am seeing screens. So thank you everyone for joining. There might be a few others who I think are in the middle of clinical services. If you're able to join us on screen, that would be wonderful. Okay. Well, we will go ahead and it's been moved and seconded that we accept this vote language. So I don't see any additional hands raised. We'll go ahead and I will call on individuals to please vote, and please remember, state your name, whether you have any conflict of interest in your vote. We'll start with Dr. Bell.
Beth Bell, no conflicts, yes.
Thank you. Dr. Cotton?
Neil Cotton, no conflicts, yes.
Thank you. Dr. Long? Okay, we'll come back to Dr. Long. Dr. Sineas?
Sybil Sineas, no conflicts, yes.
Thank you. Dr. Lair?
Jamie Lair, no conflicts, yes.
Thank you. Dr. Paling?
Kathy Paling, no conflict, yes.
Thank you. Dr. Sanchez?
Pablo Sanchez, no conflict, no.
Thank you. Dr. Talbot?
Dr. Talbot, no conflicts, yes.
Thank you. Ms. McNally?
Conflicts, yes.
Thank you, Ms. McNally. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Ms. Bata?
Lynn Bata, no conflicts, yes.
Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Oh my goodness, okay. Dr. Long?
Thank you. I'm sorry, I had some noise going on here. Sarah Long, no conflict, yes.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
Lee, no conflicts, yes. Are there any members I didn't call on since I went completely out of order? Okay. Dr. Wharton? I think I have 14 yeses and 1 no.
Well, 13 yeses and 1
13.
no. There are 14 members of the committee.
Thank you. Thank you. So the motion passes as proposed. And with that, we will open up for comments from our voting members as well as our liaisons if they wish to make any public comments about the vote. So Dr. Talbot, I see your hand is raised.
I have two couple quick comments. I'm going to reinforce vaccines for adults over and over and over again so we can get rid of this inequity and improve vaccination rates for all adults regardless of age. The second thing I want to highlight is something that Dr. Daly mentioned, is that we are still learning about COVID and this data is going to change all the time. And so I think we need to constantly reevaluate. We actually don't know when the COVID season is. So fall may not be the time for us to be voting on and recommending vaccine. It may be spring. So I just want us to remember that and to reevaluate continuously and vaccines for adults. I'm done. Grace, you're on mute.
Thank you. No wonder why Dr. Sanchez couldn't hear me.
I was wondering if I was next. No, as voting against it, I just want to be clear that I am not against this vaccine. The data do look great. The limited data that are available does look great, even though it may not be the most the circulating variants currently, but it has neutralizing activity against the other variants and certainly the ones that are circulating now or expected to be circulating. I I am very much pro-vaccination and certainly high-risk groups. I just want to comment that we have extremely limited data on children and infants and other individuals, and so I think that needs to be made available then to the parents. And I also think that in certain circumstances, we do have to be concerned about potential side effects, especially in the in young adults and young adult males. And so I think all of that needs to be weighed, and so that's why I hesitate to make it just a universal recommendation, even though I do support vaccination with the COVID vaccine. Thank you.
Thank you. Ms. McNally?
Thank you. I really just want to emphasize for consumers that it's very important as they consider this particular vaccine that they talk with their healthcare provider to make sure that they have all of the best information possible to make a decision to protect themselves against this circulating strain and other strains of the COVID-19 virus. Thank you.
Thank you. Dr. Lair?
Thank you. My office staff just asked me, and I think it's probably useful for the entire country to now be reminded that the bivalent vaccine is no longer recommended. And so it should not be given and should be taken off the shelves and put to the side. They were thinking that they were going to be giving it until we got the new one in, but I understand that by this vote, we're recommending not to use the bivalent vaccine anymore. So that's important for all the offices in the country. Thank you.
Thank you. And then just to clarify, I think from the FDA authorization yesterday, the bivalent vaccine is no longer authorized by FDA. Thank you. Dr. Duchin.
Thank you, Dr. Lee. I just have a brief statement on behalf of the Infectious Disease Society of America. IDSA supports that ACIP's new recommendation makes COVID-19 vaccines available to all persons 6 months of age and older who choose to be vaccinated. Most importantly, we strongly encourage the updated 2023-2024 vaccine for all persons who are at increased risk for severe COVID-19, including everyone 65 years of age and older, and the many, many, many adults under 65 years who have one or more underlying medical conditions that place them at increased risk for severe infections. Thank you.
Thank you, Dr. Duchin. I don't see any hands raised. Last call. All right, well, with that.
Oh, I'm sorry. It's Dimitri Daskalakis. One very quick last call. So I just wanted, I apologize. It's the hand mic and our speed in turning it on. I apologize. So first, I want to just say thank you to everyone on the committee for all the amazing work and just a really rich discussion. I think this is sort of where the magic of ACIP is, that after all of the thought and all of the discussion and such a clear process to go from data into recommendation, it's so inspiring to see the process and to hear the voices and to hear opinions in all directions. And I just also want to give a very specific and loud shout out to the NCIRD staff that works so hard to make sure that all of this magic happens and supports ACIP and all the work that they do. So I think that just thinking about the importance of this discussion and the importance of the decision in protecting Americans from severe manifestations of COVID, this process, its transparency, and just the amazing thought and work that has gone in from every direction is really inspiring. And I don't want to keep you anymore from the rest of your day, but I just wanted to once more say thank you so much for all the amazing work.
Thank you for those comments. And I want to just echo my thanks to all of the speakers and all of our ACIP ex officio and liaison members for your work today and for your ability to come together for somebody's going to count for me, but I think our 34th meeting since the pandemic. With that, by some miracle, we have ended on time. So I thank you all for your efficient, thoughtful, robust discussions around this issue. We certainly appreciate it, and I know the public appreciates being able to hear the deliberations. That this is not an easy decision, but one that has been really at least well considered from all different angles about how we get to the decisions we do. So thank you again. We look forward to seeing you soon. Have a great day.